share my screen. Right. All right. So we're going to talk about sleep, scheduled, unscheduled drugs, and we're going to review substance abuse again. All right. So again, pharmacokinetics, pharmacodynamics, definitely know like what substrates the medications are broken down by. Like for instance, methadone is broken down by what? No? 2B6, right? 2B is in boy 6. 2D6, 2D is in dog 6, and 3A4, right? Majority is 2B6, a little bit is 2D6 and 3A4. But if you give someone, let's say, Prozac, and they're on a high dose of methadone, even though it's not really going to increase 2B6 as much, it's going to increase 2D6, we can still push someone over the edge, right? So even if someone's on Prozac and they're on methadone, they might have what? What can you see if someone's on methadone and you increase the dose? Sedation, right? You know, whatever the constipation, you know, the effects of an opioid. All right, so just know that. Okay, sleep circuits. Right, it's very important to know there's two parts of sleep. There's the sleep drive, right, which makes you kind of fall asleep, and there's the wakefulness drive that helps you stay awake. Right, so the sleep drive is kind of like, you know, building up of adenosine. Right, you guys know what adenosine is? Have you heard of adenosine? Adenosine is a protein in your body that builds up. That's why when you drink coffee, what is coffee considered? An adenosine antagonist, right? Caffeine is an adenosine antagonist. Adenosine is a weak, mild, like depressant, similar to like GABA, not as strong as GABA though. So, you know, when adenosine starts to build up, it's gonna start suppressing your other neurotransmitters, and people start to get drowsy, right? That's how things happen during the day. Adenosine in the morning, when you, let's say you're working a normal work schedule, right? You wake up at 7 and you go to bed at 10 p.m., right? You're probably the most alert between 7 a.m. and like 11 a.m. As the day goes on, you tend to be more tired, right? Because your adenosine starts to hit a certain level. But if you drink coffee, let's say at 11 a.m., that's blocking the adenosine receptors. So therefore the adenosine is not kind of building up too much. It's not hitting that, it's not suppressing your other neurotransmitters. Does that make sense? Right? That's why coffee is an adenosine antagonist, right? It also has mild antidepressant properties also, right? Caffeine does tend to make people feel a little bit better about themselves, all right? So no, the wakefulness drive, right? Which is your projections from the what? From the brainstem, right? You have something called ARAS, your ascending reticular activating system, right? We talked about that in the early lectures too, because you need that to innervate your cortex, right? So you have projections of the cell bodies of a lot of neurotransmitters, right? So if the projections for serotonin would come from where? What is RA?
Raphe nucleus.
Raphe nucleus, very good, right? So a lot of your serotonin is coming up from the raphe nucleus, right? And that will secrete a lot of serotonin. What about your norepinephrine? Comes from where? Brainstem. What is it called? The cell body. LC. What does LC stand for?
Locus, I'm probably mispronouncing. Cerulean.
Very good. Locus coeruleus,
Locus.
right? So that's your main norepinephrine. What about dopamine?
Was the VTA
Very good.
and the striatum?
Very good, right? So you have two main ones, cell body. Ventral tegmental area, which is the reward pathway, which we'll talk about more in addictions, right? A little bit more. And you have the substantia nigra, which is for movement, right? The SN. So ventral tegmental area, substantia nigra, major, you know, dopamine producing cell bodies, all right? What about histamine? What does TMN stand for? Tuberal mammillary nucleus in the hypothalamus, right? And then you have basal forebrain, which is acetylcholine. I'm probably not going to test you with these specific sub-bodies, but just understand that the projections from your, you know, your midbrain is what comes up, and that is what innervates and keeps you aroused, right? Arousal. What does hyperarousal do? It makes people anxious, right? People have PTSD, they're hyperaroused, they're looking left and right, they're worried that something bad is going to happen, right? That's too much, quote unquote, norepinephrine, maybe, or too much dopamine, right? What happens when you don't have enough neurotransmitters? You're hypoaroused. So you have poor cognition, you might have ADHD, or you might just be depressed and lay in bed all day, not have any, you know, energy, no motivation to do anything, right? See what's a balance? You kind of has to be in the middle. So if you look at the Stahl book, there's the wakefulness. You just see it. It's like what do you call that? A spectrum that goes from hyperaroused, where someone is like pretty much depressed, all the way to someone hyperaroused, in which almost they're psychotic, right? Too much, and then too little. I know it's oversimplification, but it's a good way to kind of understand it a little bit. What is orexin or hypocretin? Is another name for it. What is that? Why is orexin and hypocretin important? What does it do?
It stabilizes your wake circuit.
Very good. So when there's a cutoff when you're ascending reticular active, for instance, if someone doesn't have enough serotonin or norepinephrine or dopamine, your body will produce orexin, hypocretin. It's kind of like an emergency circuit, right? So for instance, like if the power goes out in your house, you need a generator to keep your power going on, right? So hypocretin is one of those things too. It'll wake up those other parts of your brain that might have been relying on the other neurotransmitters, right? So let's say there's a deficit in serotonin or epinephrine, your body will secrete hypocretin and it'll keep you awake, right? There's a new class of hypnotics now that are called orexin antagonists. Have you heard about them before? Suvorexin, lamborexin is one I prescribed them to a few of my patients. It works pretty good. What is the benefit of using an orexin antagonist as opposed to Ambien or Lunesta, zopiclone? Why would it be better for some patients?
Is it less addictive or like less respiratory depression?
Yes, okay, that's good. Yeah, very good. Yep. So sleep apnea might not be a contraindication, right? History of alcohol abuse or benzodiazepine use might not be a contraindication, right? And then orexin antagonist, you can give those to those patients without suppressing respiration, right? Similar to opioids, it suppresses your body's ability to recognize a buildup of carbon dioxide, right? When you suppress those neurons, your body doesn't know, carbon dioxide builds up, you're not breathing as much, and people die of respiratory depression, right? So the sleep circuit, right, regulated by GABA. So your SCN, what does SCN stand for? It's a part of your brain that regulates light, right? So your body will know when it's nighttime. So suprachiasmatic nucleus, or SCN, is like the pacemaker of your brain, right, for sleep. So once your SCN receives a signal that, it's getting darker, right, the light's starting to go down, that tells your body to start releasing GABA, and also tells your pineal gland to start releasing what? Your pineal gland secretes what? What hormone? Melatonin, right? So your suprachiasmatic nucleus starts to know that it's, the sun is setting, it's getting darker, all right? Increase GABA. GABA starts to tell your other cell bodies, start decreasing norepinephrine, start decreasing dopamine, starts decreasing all these other neurotransmitters that you need for your ascending reticular activating system, right? And that helps you fall asleep, right? So GABA goes up, tells your body to fall asleep, all right? Any questions? No. Okay. These are the three most common causes of insomnia. Not causes, I'm sorry. These are the three types of insomnia. So you have initial insomnia, which you ask someone, do you have difficulty falling asleep, right? Pretty easy. Everyone suffers from that once in a while, initial insomnia, right? Could be caused by a lot of things. Could be pain, could be anxiety, could be, worrying about the next day. Middle insomnia is when you wake up in the middle of the night, right? So if I interview a patient and I want to do a good screening for sleep, I'll say, do you have trouble falling asleep, initial insomnia? Do you have trouble staying asleep, middle insomnia? Or do you have trouble, sleeping, or waking up too early? You have trouble waking up too early, right? You have to be up at 7 to leave for work at 8, but you're waking up at 6 or 5:30, and you can't go back to sleep no matter how hard you try, right? Terminal insomnia usually is a sign of depression, right? If you look at a lot of the symptoms of depression, terminal insomnia will be there. Right? People will have trouble sleeping, restful sleep, because they'll wake up an hour earlier and they'll feel exhausted, right? I don't have to wake up till 7, I'm waking up at 5:30, I'm waking up at 6, and I can't go back to bed. And then I have to take naps during the day because I'm exhausted, right? Terminal insomnia, all right? How do you treat initial insomnia? What would you give them? Initial insomnia. These are the most options. You can give me class of meds, you can give me name of meds. It's up to you.
You could use melatonin.
Okay.
Antihistamines like Visceral or something like that.
Antihistamines, yep. Remember, you need histamine to innervate. Remember, histamine is being secreted by your ascending reticular activating system, right? If you block histamine, therefore, you're going to decrease arousal, right? So people start getting sleepy. Good. Antihistamine. Diphenhydramine is one. Hydroxyzine pamoate or hydroxyzine hydrochloride is another one, right? Melatonin. There's over-the-counter melatonin, right, which you can tell patients to buy, but there was a report by Consumer Report, I think like a year ago, in which I read the article, and apparently they took a bunch of like melatonin from like Target, a bunch of other pharmacies, and they actually took it to a lab to see how much melatonin was on there. And the potency was all over the place, right? It would say 5 milligrams of melatonin gummies. When they checked it, it was like less than 1 milligram. Or it would say 10 milligrams and they checked it and it was like 30 milligrams. So notice how the things are all over the place, because since it's not FDA regulated, right, over the counter, no one really knows the quality control, right? So what I do now is if someone's taking melatonin, I actually prescribe them melatonin called Ramelteon. Ramelteon is a prescribed melatonin, and it comes in 7.5 milligrams. So you know they're actually getting 7.5 milligrams of melatonin. All right, you can do that too. Ramelteon is prescribed melatonin. All right. Any other meds you can give them? What if someone has depression and they're having trouble falling asleep? What would be a good medicine to give them for initial insomnia?
Trazodone.
Very good. Why? What's the mechanism of action of trazodone?
5-HT, is it 1A?
Okay.
Oh,
Is it an
right?
agonist or partial agonist on 1A?
Partial.
Very good. Okay, what else?
Doesn't it do it? It depends on how high up the dose you go, like from 50 to, or is that Seroquel? More
Oh,
like
it does. Yeah, trazodone also if you go up. Yeah, but let's say 50 to 100 milligrams for
Mhm.
hypnotic. What does it do? Antihistamine, mostly, right?
Okay.
Yeah. So the funny thing about trazodone, it has many different, mechanisms of action, right? Number one, at high doses, it is serotonergic. It will help block some serotonin reuptake pumps and it will increase serotonin, right? It is antihistamine, that's true. It helps you sleep. It is anticholinergic, so it might cause some dry mouth, poor concentration, right? All the anticholinergic side effects. It is an alpha blocker, so it will drop blood pressure a little bit, right? That's why sometimes you give trazodone because it blocks histamine, it blocks serotonin, right? It's a 5-HT2A antagonist. It also blocks norepinephrine. It's an alpha blocker. So you're hitting 3 neurotransmitters from the ascending reticular activating system, right? So let's say someone tries Benadryl, right? It doesn't work for them. Why try hydroxyzine? It's 2 classes. You're just blocking histamine. You think that's going to work? Probably not. So I would climb up. I would say, okay, let's try trazodone then. Because you're blocking serotonin, 5-HT2A antagonist, right? It's also 5-HTC antagonist. It's also an alpha blocker, alpha-1 blocker, right? So you're blocking the norepinephrine pathways too. So see what I'm saying? It's blocking different pathways and it might help people sleep. Obviously, if someone doesn't have depression, you probably don't want to do trazodone first, because why would you want to block norepinephrine unless you had to, right? Maybe try antihistamine first. But if someone does have depression, maybe you can add trazodone to Prozac, right? Or trazodone to Zoloft, which you guys see a lot, right? Because it's synergistic, which means that the properties of the trazodone might help the properties of the SSRI you're giving also, right? Middle insomnia. What medication can you give for middle insomnia? This is a little more challenging. Would you give a short half-life medication or a long half-life medication?
Long half-life.
Okay, and give me an example.
The Lunesta.
Zopiclone, and what's another one that's long acting?
Ex Ambien,
All right.
depending on if it's immediate or extended, right?
Yeah, it's for Ambien, it's called CR, controlled release.
Okay.
All right, so Ambien CR would probably be best for middle insomnia. All right, those are probably the ones I recommend. Those are the ones I use for middle insomnia. Right.
Do you
So
ever use like can use like Klonopin, or is that really just if they have anxiety long term, or would you use it as an initial sleep
I
aid?
don't. Yeah, if someone has anxiety comorbid, then it could be argued it, but I don't think using a because a benzo is like a blunt instrument. Sure, it blocks GABA, but then you're blocking a bunch of other stuff, right? You can also cause, you know, sedation in the morning, more accident prone if they're older, benzos, they get out of bed, they might fall down. So it's a lot of risk benefits. So I personally won't use a regular GABA drug, right? I would use a Z drug hypnotic, which is specific GABA receptors that don't work on anxiety, but only work on the GABA receptors for sleep, right? You know the difference between GABA drugs and uh, the non-hypnotic GABA drugs, right? They both work on GABA A, but there's specific subunits of the GABA, right? You don't need to memorize the one, just know that a medication like Xanax or a medication like Klonopin work on the GABA receptor, but it works on all the subunits that work for anxiety, that cause amnesia, that can cause, issues with sleep, right? Sometimes you don't want that. If someone just has issues with sleeping, you don't really need to target anxiety. You just want to target the sleep subunit, right? And it's not going to cause amnesia either. People are not going to have forgetfulness, usually. You guys understand that, right? There's the GABA drugs that are regular benzodiazepines, and the non-benzodiazepine hypnotics, like we talked about, zopiclone, Ambien, Zolpidem, the Z drugs. All right. And in terminal insomnia, usually the recommendation is treating the underlying cause. So if someone's suffering from depression, treat the depression, right? SSRIs, you can do trazodone, you can do mirtazapine. What's interesting about mirtazapine? When would you use mirtazapine over trazodone? What's the benefits of mirtazapine? It's a 5-HT3 antagonist. So if someone has issues with eating, they have low appetite and they have nausea, mirtazapine might be a good method. Say someone's depressed and they don't have a good appetite and they're having insomnia also, I would use mirtazapine for that, right? That's why mirtazapine can cause weight gain because it makes people, eat a lot. It's a 5-HT3 antagonist and also antihistamine, right? Those two properties. Antihistamine, 5-HT3 antagonist, it messes with your satiety hormones in your body. It makes you more hungry. You don't know when you're full, and people tend to overeat with that, right? Maybe use it temporarily. I also use even though we're not talking about akathisia right now, but mirtazapine I use for akathisia also. If someone is taking antipsychotic medication, they have akathisia, mirtazapine would be a good medication for that as well. All right. So initial insomnia, pick and choose. You can do melatonin, Ramelteon if you want to prescribe it, anticholinergic, antihistamine medications, trazodone if they have comorbid anxiety or depression, mirtazapine if they have poor appetite also with insomnia. All right, middle insomnia, long half-life medication, Lunesta/azopiclone or Ambien CR control release. All right, terminal insomnia, they wake up earlier than expected. You can treat the underlying cause, all right, which would be depression or anxiety. All right, usually if you treat that, it gets a little bit better. Terminal insomnia is probably the most difficult to treat. Usually it's residual. This is what I was talking about before, the ascending reticular activating system, right? You don't have to memorize all this, but just have a general understanding of how it innervates, your cortex. All right. Just know this again for alcohol, right? Just to review alcohol again. What are the medications that you would use to treat someone who is, using alcohol? What would you use? What are some medications we can use for abstinence?
Naltrexone.
You can use naltrexone. Okay. Yeah. You can actually give it to them even when they're using. You can give them naltrexone. Yeah. What's another one? That's what we were talking before, drinking. Someone mentioned, Stahl said using something while taking a medication. Usually, even if you give them naltrexone, you don't really tell them to stop drinking because when they drink, they don't feel the reinforcement and they'll be like, why am I drinking anyway, right? Because you're giving them naltrexone. The only thing is they can't really stop cold turkey, so you would have to actually switch. You have to add a medication. What is it to help replace the alcohol so you don't have withdrawal?
Librium.
You could, yeah, which is what? A benzodiazepine, right? Yeah. So you use a benzo to bridge them. You can use Librium, you can use Ativan, all right, and you taper them off. You have to find the dose that gets them out of withdrawal, and then you taper them slowly over a couple of days. All right. The danger is delirium tremens, right? DT, it's called. People can have seizures, they can have psychosis. There's also something called alcoholic hallucinosis, in which people will have hallucinations while they're drinking. All right. Sometimes they see little people, believe it or not. The clinical findings, they'll see like midgets. If someone's mentioning seeing little people, it's probably alcoholic hallucinosis. All right. So naltrexone, if you give someone naltrexone, what receptor would it bind to here to stop the euphoric effect of the alcohol? What receptor?
The mu receptor?
The mu opioid receptor. Very good, right? Because there's wanting, right? Someone wants something, and there's pleasure, right? Where someone's actually if someone wants something, that's more dopamine, right? I want to drink alcohol. That's dopamine in my brain, right? Now, when I drink alcohol, I feel the pleasure of using that substance. That will be opioid driven, all right? So the reason why, you're stopping that behavior because when they drink and the naltrexone is on board, they're not getting that euphoric effect, right? It's blocking the VTA from secreting dopamine to the nucleus accumbens, right? Or ventral striatum. Therefore, they're not going to feel pleasure. You can say, why am I drinking then? I don't feel anything from it, right? You can give them PL naltrexone 50 milligrams. Why is that a problem? Why is it not as effective as injectables?
Long acting, that they're getting it like a steady state. Like,
That's true. People will just stop I'm going to go out with friends tonight, so I'm not going to take my naltrexone today. 50 milligram PO, right? Simple as that. Adherence, people forget, and then they'll drink, and then they'll feel euphoric again, and then you're back to square one, right? The interesting thing about like pleasure is when your VTA is secreted to your nucleus accumbens. This is just extra information, right? But this is you understand if you want to specialize in addiction, is that when your VTA secretes dopamine and it hits the nucleus accumbens, right? There's actually a negative feedback loop. Your nucleus accumbens will actually secrete something called dynorphins, which will actually tell your body to stop releasing dopamine. So in a way, it actually shuts it down. So people will eventually get that first high and they'll feel really good. But if they keep doing the same substance again, they're seeking that same high they got the first time, but it's not happening because it's that negative feedback loop from the dynorphins of your BTA secreting backwards, and you're not getting that same pleasure. People are seeking it, and that's what they want, but then it becomes more dopamine driven. Get it? You ever hear people use something like that same high or that same buzz that I got the first time is not the same, and they're always seeking it, but they don't get it. Right? So that's actually it's a reverse feedback loop. All right. This, since you guys are prescribing, just have a general understanding, right? Schedule 1, we don't prescribe that. All right. Schedule 1 is your illegal drugs. All right. You'll be prescribing Schedule 2, which is your pain medications, right? Then you have Schedule 3. Then you have Schedule 4, which is your benzos, right? And you have Schedule 5 also, all right? Just know Schedule 1, we don't prescribe that. You prescribe Schedule 2 to Schedule 5, all right? Pretty straightforward. These are the opioid receptors, right? So you have the mu, which is the U, right? So I want you guys to know what happens if that's innervated, right? If someone takes heroin, obviously you're stimulating the opioid receptors. So what's going to happen? They're going to have euphoria. They're going to have sedation, right? But I wanted to point something out here. It's not on this slide, but just know that there's data out there that the kappa, the K receptor, actually, when you innervate it, it actually, there it is right there. Dysphoria, right? You notice that when people use opioids, they also feel dysphoric sometimes. They get agitated, right? Not just from withdrawal, but also from taking it. Because the kappa receptor, if you hit enough of those receptors, actually makes people feel depressed or not happy, right? So there's actually a new class of antidepressants that they're trying to create now that are actually kappa antagonists. A lot of newer class of medication. Just to keep that on your radar, all right? So mu and delta are more for like, pleasure and, can cause, it also has antidepressant properties. That's why people feel a little bit better. But you hit enough kappa receptors and people actually don't feel good. They get agitation, all right? So like I said before, if you want to memorize and understand what intoxication looks like, right? And then when they stop the substance, then know what the reverse is, right? Which would be the opposite, right? So for instance, opioids would cause respiratory depression, constipation, pinpoint pupils, right? The opposite would be from withdrawal. This is just the brains of people with alcoholics. Obviously, you can see it causes brain issues, right? Wernicke's encephalopathy, like I said, people are chronic alcohol users and not getting enough thiamine. So before you give them glucose, you need to give them thiamine, right? Because your body needs thiamine to make energy. And if it tries to make energy without the thiamine, you put glucose there, it can cause brain damage, right? Irreversible brain damage, actually. It can lead to something called Korsakoff psychosis. Korsakoff psychosis is actually non-reversible, all right? So Wernicke's, if you catch it early, it's reversible. Korsakoff psychosis, once it gets to that point, it's irreversible, all right? That can cause, I'm sorry, last half hour we were talking about lawsuits, but that'll be lawsuit. All right, CWA, understand what a CWA is, what it's for, alcohol withdrawal. Yep, understand that, when you're giving someone benzos, you're also checking CWA and you want to taper them off, right? If someone's getting the right dose of benzo, the equivalent to how much alcohol they were drinking, would they score on the CWA or no? Will they score high? No, they wouldn't, right? They shouldn't. So they should be scoring very low on the CWA if you're giving them the correct replacement of the alcohol. Sorry, which is benzos. Sorry. These are just some of the treatments for alcohol use and opioid use, all right? But this is for alcohol. Oral naltrexone, right? Blocks opioid receptors. People don't feel pleasure, so why drink, right? Naltrexone is better, long-acting injectable. Get an injection. Rivia, I think is the name of it. You give it once a month. Acamprosate, right, is another one. It also helps with cravings. Just make sure kidney functioning. That's important. Acamprosate is very heavy on the kidneys, so make sure GFR, BUN creatinine is normal, all right? Disulfiram, it's negative reinforcement because when people drink, what happens? They throw up, right? It does work, but the problem is if someone knows they're gonna drink, they know what disulfiram does, they're just gonna, throw it out and not use it, right? Is it ethical to give someone disulfiram and not tell them what it does? No, right? Because if someone has a lot of medical issues, you can actually kill them. Disulfiram can kill somebody, so be careful. What is another contraindication of this disulfiram?
Family
Psycho-
history of psychosis,
Very good. Why?
because it can actually induce psychosis because it stops the breakdown of dopamine,
Very
right?
good.
It
That's
builds and
important.
builds up.
Very good. Yep, dopamine builds up and it can cause psychosis, right? Anecdotally, I've seen patients become psychotic in disulfiram and we stopped it and the psychosis went away. There were some patients also that were put on disulfiram and their psychosis started and never went away, right? So I don't know if it was genetic loading in which the family history was there. It's unclear, but just know once psychosis happens, sometimes it doesn't always go away, right? That's why I tell patients not to smoke marijuana because it is psychomimetic. And sometimes once you get psychosis that first time, it doesn't go. Sometimes if you're lucky, we give you antipsychotic for a short amount of time and it goes away. But sometimes other people, it's not worth it. It's not worth the risk, right? Smoking cessation, we didn't talk about this last week, but just know, nicotine replacement therapy is easy, right? Just know how much they're smoking and you give them the patch, all right? The gum, varenicline, be careful with patients who have a history of suicide because it can induce suicide in patients. So if someone has a family history of suicide or has a family history of someone committing suicide, I probably will stay away from varenicline, all right? What does varenicline do? It works on what? Alpha A4 beta 2 receptors, right? Which are on what receptors? Nicotinic receptors, right? What does it do? Is it an antagonist? It's a partial agonist. Why is a partial agonist going to help? Why do you think it would help with nicotine cravings? Can you have nicotine and varenicline bind to the receptor at the same time? Yes or no? No, you can't, right? What do you think has a higher affinity, varenicline or nicotine?
The drug, the
Yeah,
varenicline.
varenicline, right? It's the only way the medication will work. So if someone ever made a medication and the affinity was not as strong as the affinity of the endogenous neurotransmitter. Say, for instance, if I wanted to make an antipsychotic, right? And the Ki value of the antipsychotic was not stronger than the body's regular dopamine, dopamine would go on the receptor and punch out that medication every time, right? It would be useless. So whenever they make these medications, they have to make sure that the affinity of the medication is stronger than the endogenous version of that medication. Usually partial agonists are, right? Like Abilify, cariprazine, brexpiprazole in psychosis and mood disorders, and obviously varenicline for substance use disorder, right? So if partial agonists are the only ones that can be in the receptor and someone's smoking, what's going to happen? That partial agonist is so strong that none of the nicotinic receptors are going to be stimulated by the smoking, right? Therefore, people are not going to get the euphoric effect, and they're going to say, well, why am I smoking anyway, right? Wellbutrin is similar. Wellbutrin works through dopamine. So like I mentioned to you before, dopamine has to do with cravings, right? So if you're giving someone a little bit of dopamine, because what's the class of Wellbutrin? What does it do? It's a what?
Dopamine and norepinephrine.
DNRI, right? Dopamine norepinephrine reuptake inhibitor. So it'll increase the amount of dopamine, right? Just enough so that it stimulates the reward pathway, not enough to induce euphoria, but enough so that that those receptors are getting something they're not going to crave, cigarettes. Does that make sense? So you're giving them a little bit of dopamine to kind of stop the cravings, but not enough where it's causing, reinforcement and euphoria. All right. And electronic cigarettes are a little controversial. They use that a lot in Europe now. So in Europe, they actually switch people from cigarettes to e-cigarettes. I do have some patients that do that now, but we don't know what the long-term risks are of e-cigarettes. But we do know what the long-term risks are of cigarette smoking, right? So I guess it can be argued that e-cigarettes harm reduction is better than them smoking cigarettes. All right. But again, we don't have data to show what's going to happen 10 years, 20 years down the line if they continue using e-cigarettes, right? No one really knows.
What type of replacement therapy would you initiate? Like, would you start between like patches, lozenges, is just what they agree to, or is it?
So most studies show that you have to do a combination of patch with medication with psychotherapy, right? It's usually not one. And a lot of times people will try and then they relapse, right? Anyone here smoke cigarettes trying to get out? It's hard. It's probably one of the hardest addictions to stop. So people will fail and they have to restart again and you have to try different treatments, right? Sometimes it could be due to, untreated other issues, like someone has depression and there's, medicating with nicotine because, that's their vice. Maybe you treat the depression at the same time, along with nicotine replacement therapy, right? It's a combination of both. Marijuana, we don't really have good treatments for marijuana users, or at least, pharmacodynamically. If they've tried synthetic anandamide medications like that to kind of get people off marijuana, but it's very challenging to do it. Just know that marijuana is inhibitor of 3A4, 2C9, and 2C19. All right, so 3A4 could be statins, it could be benzodiazepines, it could be some antipsychotics. All right, 2C9 could be Depakote. Right, 2C19 could be Zoloft, Lexapro, Celexa. Right. Just know that if they smoke, they can have more side effects with the medication on top of the pharmacodynamic, psychomimetic properties of it, or the depressant or the anxiety promoting parts of it, right? Remember, our body is used to partial agonism of cannabinoids, not the full agonism that these, synthetics are giving us. So people's bodies will respond very differently. All right. So any questions? We can talk about substance abuse, we can talk about sleep. But I mean, just from understanding withdrawal and tolerance, definitely no tolerance, right? So what is tolerance? What is tolerance to a medication? What does that mean? What does tolerance mean? No difference between tolerance, dependence, addiction, right? So tolerance means that someone is no longer responding to a specific medication because their receptors, what? They adapted, right? Are they downregulated or upregulated? Therefore, you have to increase the dose, right? Dependence means that when they stop the medication or substance, they start having withdrawal. That's dependence, right? Tolerance means you need a higher level to get that same effect that you were getting before. The treatments for opioids, that's important. You guys want to do another lecture before the final, or because technically I think this is going to be our last lecture, so I don't know. It's up to you guys.
Yeah. Can we do like a review it? I really would love to like review SSRIs a little more in depth, but like not tonight. I want to focus on this one.
Oh,
Would that be okay before the final?
sure. Anyone sign up for 517 with me or no? Anyone in my 517 class?
I think I did, yeah. It's you and another professor?
I don't know who else is teaching. I'm not sure.
I saw like it was your name, but then like I think once you like go into your section, there was like a woman's name with it.
Not sure. Yeah, they're short. They're short. I wasn't gonna teach 517, but he said they were short and needed me, so they're okay.
For this test, with the receptors, you said you're not gonna go as in depth because I know there's like the different histamine receptors I was reading.
Oh no, I'm gonna go about receptors. Yeah,
Oh
but
yeah,
like
can
the
we?
brain parts, like like the connections or the arcuate nucleus and all that stuff. You don't need.
So okay, so like for the histamines, because I know histamine even Stahl was like, when you think histamine, you think it's so bad, you think antihistamine, which you shouldn't because it is the wake. So there, it's the autoreceptors H3.
Yes.
So that's gonna shut it off
Mhm.
and make you more drowsy then,
Yes. Yeah.
right? So then H1 is the one that the antihistamines work on more.
Yes. H1 are CNS. H2 is in your stomach, right?
Okay.
Yeah. H3 are the autoreceptors that shut it down. Yeah. So actually, to answer your question, it's blocking H1 receptors, not
Okay.
H3 is the shutoff valve, right? If you block the shutoff valve, it's actually going to increase the amount of histamine. It'll keep you awake.
So are there like H3 agonists then that, or is that
Modafinil,
nothing?
modafinil,
Okay.
modafinil. But it's, yeah. We didn't talk about it much, but if someone has narcolepsy, you will give them modafinil. Yeah. It's a histamine agonist and a mild dopamine reuptake inhibitor too. Yeah. Good question. I'm sorry, I should have touched on that. Yeah. For people who have sleep-wake disorders, if they have a hard time arousing themselves, right? They would need something to increase histamine. Modafinil is one of those medications. Sometimes you give them stimulants too, right? Ritalin, sometimes Adderall. But I would try modafinil first because it tends to be less potent.
So when someone's in withdrawal, like let's say, I know every hospital is different. Like the hospital I used to work for, they used to give Suboxone, for cows. But I was talking with them other students, we didn't know if initially you were saying you should give buprenorphine, and then when they discharge the hospital, transition them to Suboxone, or is it just really
No, it
dependent?
doesn't matter. I mean, they're the same. The active component of Suboxone is buprenorphine anyway. Buprenorphine is just by itself. It doesn't have the naloxone with it.
Okay.
I mean, most places will just give Suboxone because it's safer, right? The naloxone will save them. I guess from a cost perspective, it might be cheaper just to stock buprenorphine. But for best practice, there's no reason to give someone, not give someone Suboxone, right? Because it has naloxone there. Plus, it comes in flavors. Suboxone comes in orange flavor.
I actually had a patient this week that said that he gets like a Suboxone monthly injection. Do you know?
Yes, they do have those injectables too. They do. Yeah. It's called Sublocade. The only problem with that is it has to be stored on site and you need security and people break into clinics because of that. And also it puts a bubble in your stomach because it slowly disperses through that bubble and people actually cut it out and they sell it. Yeah, they cut out the bubble. Yeah.
Oh, thanks.
I don't know how they figure this stuff out, but yeah.
That's
The
crazy.
stomach, the bubble's there, they cut the stomach out, they cut the piece out and they sell it. Yeah. Probably find it on eBay. Look it up, Sublocade.
I was gonna say, and that same patient, the
Release the skin.
doctor was trying to give him morphine. I'm like, no, he's on Suboxone. He can't get morphine. He's gonna have worse withdrawal. And I thought of
Oh,
this
really? I
class.
didn't know that.
No, he was a resident though. Caught him.
Very good, good. Good that you caught that. A patient comes to the ER and is very sedated and says, I took something that was prescribed to me by my doctor. What do you think it was?
Benzos? I don't know.
Very good, benzos. Yeah, that's it. Yeah, benzos. So no, also like, combining things. So whenever you give someone a certain medication, it has a certain side effect, right? This is just in general now. If the side effect is like sedation and the other med you're giving also, it's common sense, causes sedation, of course, the person will be high risk of sedation, right? Or let's say agranulocytosis, right? You give someone clozapine for treatment-resistant schizophrenia, and then you put them on Depakote, which we do sometimes for seizures. Both of those medications suppress white blood cell count. So there's a higher risk of them of developing neutropenia, right? So you probably would order, even though we're not talking, when you do 517, we're going to talk about labs. It's going to be a lot of more than this, but you have to do CBC to make sure that, labs are okay, right? They don't have neutropenia, that their platelets are okay and all that other stuff, right? Or someone takes trazodone as a hypnotic for sleep, and that's an alpha blocker, right? Trazodone is notorious for causing priapism, right? Which for females is an inconvenience, right? But for males, they lose sexual functioning if you don't go to the ER right away. If you give them risperidone, which is also an alpha blocker, their risk of priapism goes up a lot more, right? And you'll be surprised how many times people prescribe that combination. Risperidone and they give them trazodone for sleep, primary care doctors specifically. Not knowing that the risk of priapism goes up a lot, right? Now, what happens if they're taking risperidone, right, for psychosis, and they're taking trazodone, and now they go to a party and someone is like, hey, there's a nice drink here that has grapefruit juice, right? It's an inhibitor. You're gonna drink grapefruit juice, and now they have an erection that's lasting 10 hours, right? See what I'm saying? These all these things can compound, and you have to figure out what is it? Is it the inhibitor? Is it the medications? Like there's so many things you need to understand, not just, you know, basic stuff. Or they get put on an antibiotic, like ciprofloxacin, which is an inhibitor, right? And all of a sudden.
Can we go a little bit more into the sleep medications? Like I know Stahl was talking about I know you touched upon it, the like the Z drugs, the GABA, PAMs, and then there's I know the DORAs or
DORA is
the
a
dual.
dual orexin receptor antagonist I was talking about. So that would be the suvorexin, lamborexin, right? See, those block your orexin receptors because orexin is the power generator of your body, right? When you don't have enough stimulation, your body will secrete orexin. So what happens when you stop that? You cut off the generator, people will fall asleep.
And then dual just being like the two different
Yeah,
types of
both orexin.
orexin
Yeah, both. Yeah,
receptors.
exactly correct. Yeah,
Okay.
both receptors. Yeah, orexin 1, orexin 2. I don't know if any or just one. I think it just works both ways. I think you need to block both. I think all of them are DORAs. I'm not aware of non-DORA.
And then the benzos, I know he mentioned like a few, but could it really be like any benzo? Because or I think he was talking about the ones with a different half-life, like lorazepam. He talked about trazolam, but like, could you really be doing like any benzos, or are these the better
I would use
benzos?
Ativan or Lorazepam because it has or Librium because they have the most evidence.
Okay.
Right? Unless they're like short, and this happened at NYU when I was there. They were short like Ativan for whatever reason, so we had to use different benzos. But I would stick to Ativan or Librium if you can. Yeah,
Okay,
definitely.
thank you.
Ativan's probably better. It has no metabolites, right? You guys know what metabolites are, right? Metabolites are when it becomes metabolized, it turns to a different substance, which can cause different effects, right? Usually we prefer meds that don't have metabolites because the metabolites can confuse things. Like, for instance, clozapine is an active metabolite called norclozapine, right? Which is a cholinergic agonist. It makes you drool and it causes a lot of other stuff. So that complicates things because you don't know the ratio of the metabolite to the original compound. So sometimes it makes things complicated. So if we can give a cleaner medication that has no metabolites, it's probably better, but there are some meds that don't have that option, so you have to give them metabolite. But know what the metabolites do. All right. Any other questions? Like the student said, like Phil said, you guys saw Phil, right? He was talking a lot. He was in the same boat you guys were, right? Now he's asking for almost 200,000 a year in his job interviews, and he's getting it. So, you know, be bold, but know your stuff too. You know, if you can back it up, people will pay top money for an NP. And he didn't have his psychopharm class. I wasn't there. I met him 517, and you know, I pretty much had to teach him psychopharm all over again. Right? There was no live lectures. They gave you the style book, and it was like learning yourself.
With 517, so are we going to be talking about like what is that class going to look like? Are we going to be talking about different like disorders and then like just like wrap like and then the labs that you would be
Yeah,
ordering the
yeah, pretty
tech
much.
like
Yeah, yeah. It's
oh
comprehensive. So yeah, assessments, labs, review of disorders. Yeah. Building off everything you guys learn here, right?
mhm.
If you don't know the medicine, it's a big component of it, right?
I have a question that I don't know if it's like pharmacology related, but with sleep and comorbidities, is it sometimes hard to figure out like, is the comorbidity causing this insomnia or the sleep issues, or is the sleep issue causing the comorbidity?
Yeah, so it is tough to know. You don't know if chicken or the egg, right? So usually I'll try to treat both at the same time and kind of try to get a better history. So a lot of times if someone has a history of like poor sleep, right, I would probably do a sleep study. I would order a sleep study. I do that a lot because you don't know, are they having, difficulty breathing? Are they having obstructive sleep apnea? Are they having seizures at night? There's a lot of things that could happen. So usually a sleep study will be good. And I'll usually do a sleep study before I put them on like Ambien, right? Because you don't want to suppress their sleeping. If someone really has a history of poor sleep, a sleep study doesn't hurt. Then once you can rule that out, then yes, you can treat primary insomnia. At least you get the diagnosis there, and there's a reason to give them, long-term Ambien. We do have a lot of patients in Ambien. I know it has a bad rap to it, but if someone doesn't drink alcohol, that polyambulism that happens at night where they're like, driving to the store or they're banking or buying groceries, they don't remember. It usually doesn't happen unless they drink alcohol with it. So I usually warn them, if you go on a vacation and you're going to be going to an all-inclusive place, leave the Ambien at home. Right? Don't take it with you because you're going to be tempted to take it and you're going to be walking around, Bahamas, not knowing what's happening, right?
And do people usually feel okay in the morning on Ambien? Or does it like build up?
It depends. So females actually, now there's a warning. Females tend to metabolize it slower, so we actually give females half the dose. We used to give them the regular dosing, but I think past couple of years they realized that women are more sensitive, so they give. So Ambien and mirtazapine, females tend to metabolize it slower, so we usually start half the dose. So like for females, for sleep, I'll probably give 7.5 instead of 15 right away. For Ambien, I'll cut it in half. Maybe do 5 milligrams first instead of 10. You guys ever heard of the Ambien defense? A lot of good lawyers have used that defense for a lot of crazy things. Like people would like murder people or like do crazy things and they were on Ambien, and the lawyer would actually argue that it was because of the Ambien that the person did that. It could have been the Ambien. I mean, I don't know. I wasn't there, but it's just crazy how people argue that. But the Ambien defense is pretty popular nowadays.
And is it testable? Can you test it in the blood?
Yeah,
And you
of
can't
course. Yeah,
know
yeah,
if they
yeah.
do they get blood work? Oh, sorry, I'm getting off topic. Sorry.
Okay, no, it's all right. No one's asking questions, so you can ask me. It's fine. Yeah, you
Is
can
it
test for
like
any.
if someone gets arrested for something like that, do they immediately draw an Ambien level, or can they go home and then take an Ambien and then?
I don't know. Actually, it's a good question. I mean, routinely, it would probably be a send out. I mean, when I was working, that wasn't like a routine. That wasn't a stat test. That would be a routine. It would be sent out. So maybe. I'm sure maybe, if there's an active metabolite to the Ambien, they can probably check for the active metabolite and they'll know that obviously it was in the system for a while. That's the thing about active metabolites that's good too. You do the active metabolite, you'll know that they were on that med for a while, right? Because it stays, usually the active metabolite stays longer than the original med. So my wife watches all these true crime stuff on YouTube. That's why I talk about that stuff, but I don't know. If you want a cool gig, you could be a forensics NP, and you can testify, and they'll use your clinical knowledge. Not a bad gig.
Will the questions be written similar, I'm guessing, to last time?
Yeah, right. I'm the same. Yeah.
Okay.
Did anyone think that test was not fair? They could be honest. No one's gonna say because they're gonna be embarrassed.
Can you go a little more into the nicotinic receptors and nicotine on the body? Like I know we talked about it a little bit, like the whole length of time it takes to burn the cigarette is the same time with the desensitizing and the resensitizing of the receptor.
Yeah, you just explained it to me. So I mean, What about it specifically? I'm sorry. I don't know what you,
Like, so I guess what just like when it's like what it really means when it's like it's desensitizing, resensitizing, like it confused me a little
different
bit.
receptors in your body will desensitize at different rates, right? So for whatever reason, the people that Camel cigarettes, whatever, I don't know, I think they use that example. They knew exactly how long it would take for your nicotinic receptors to actually, go back, resensitize it where they were. So after a while, when you innervate something with acetylcholine, it's gonna what? It's going to.
Is that desensitized then?
It is desensitized, right? It's
Okay.
overstimulation. To protect itself, it's gonna downregulate, right? And not be as sensitive, right? Over time, if you keep innervating with acetylcholine, right, from the nicotine, your body's not gonna hit that anymore because the receptors are kind of compensating for that extra stimulation. So you have to do like a washout, right? You just have to stop that stimulation, which is you stopping the cigarettes. So by the time you stop cigarettes, you go to sleep or whatever, you stop the cigarettes, your receptors will automatically start going back to the way they were before, right? So now, next time you smoke cigarettes the next day, of course, those receptors are back to where they were before, and then of course it goes back to what it was, right? You can resensitize it again. Dopamine receptors take a little bit longer to go back. That's why when I remember we talked about it last week, when someone is abusing crystal meth, it could take up to 6 months for it to go back to the way they were before.
So and then is the crate like because like I guess I don't understand like so the desensitizing, resensitizing, how that's with the craving, but I guess is it just because it innervates something separate?
Yeah,
Like
it would be a nucleus accumbens, not yours.
okay.
Because there's a connection with the nicotinic receptors to the nucleus accumbens. It's that dopamine receptor that's craving that reward from what you were getting before, right? So you're smoking cigarettes, right?
Mhm.
It's stimulating your tegmental area to secrete dopamine to hit your nucleus accumbens or your ventral striatum, right? That's giving you pleasure.
Mhm.
Once you stop the cigarettes or once it desensitizes, right? That receptor is not going to secrete dopamine anymore. Therefore, that other connection, it's like, where's that dopamine? Where's that dopamine? That's the craving. You're like, hey, I
Okay.
want that. So when you take Wellbutrin, right, and you smoke cigarettes, that other connection now is going to have enough dopamine there. It's not going to crave it because it's going to say, well, I'm getting dopamine from the Wellbutrin. I don't need to get dopamine from the stimulation from the cigarettes, right?
Okay, that makes more
Yeah.
sense. Thank you. Yeah. I
Now
was
from
just
the
a little
varenicline, the same thing happens, right? It's the dopamine's being released, but the varenicline is binding to that receptor. It's not getting the same innervation, right?
okay, yes, thank you.
Right? You can visualize it. Yeah. So remember, rebound and all that stuff happens not just with it happens with psychosis too. It's something called rebound psychosis. If someone is on like a very strong D2 blocker, like Haldol, or sorry, my dog is like sticking his paw to my door. Haldol, risperidone, right? You stop that cold turkey, you have all those receptors now that are upregulated, very sensitive. So they get something called rebound psychosis, which is even worse, right? Their voices are more vivid, the hallucinations are more strong, right? They might be more paranoid. So that's why I tell patients, look, if your psychosis is under control and you really do want to stop medication, please don't stop cold turkey, right? We'll work on a plan, harm reduction. We'll do a very slow taper to give your body a chance to adapt, right? Because there's a possibility, maybe, yes, maybe the psychosis will go away. Maybe. It's slim, but there's a possibility. But if they stop it cold turkey, guaranteed, I would, 90% chance it's going to be very strong. And then, of course, those receptors are going to, get hit and they're going to be very psychotic. They'll probably be hospitalized, right? You guys have seen that before. Or even better, someone is on a very strong D2 blocker, right? And they go to a hospital and a resident who's still learning, doesn't know what they're doing, puts them on Abilify, right? What's the Abilify? You can only have one molecule on the receptor at the same time. That Abilify is going to bounce off that medication, and Abilify is not a strong antagonist. So they're going to have rebound psychosis from the Abilify, right? Even worse. They put them on Abilify injectable for 30 days, which stays in the system for 30 days. And now the patient is not going to respond to any antipsychotic because the Abilify is going to be there for 30 days. It has a high affinity. And you give them as much Haldol, risperidone, olanzapine, and the Abilify, which is one of the highest affinities, will stay in the receptor. People will be psychotic for that whole month. There's nothing you can do about it. Right? I'm sure you guys have seen that in the hospital. Right? That actually happened in I want to say which hospital, but it's a pretty prestigious hospital. The doctors were like, what's going on here? The patient is not responding to any antipsychotic. We're putting them a bunch of antipsychotics. Well, I'm like, I read the chart here. They were put on Abilify Maintainer a week ago. Obviously, that's going to take another 28 days to wash out. Whatever antipsychotics you give them is not going to work, right? Because the Abilify is there for 28 days. And any antipsychotic you load them up on is going to keep bouncing off. So all you're doing is wasting medication. And you could probably give them side effects from it. So what do? Give them benzos and let them sleep it out. right? Unfortunately, or restrain them if you have to, if they're very violent, but it sucks. There's nothing you can do for the 30 days that the Abilify is there. It's a no-win situation. Patient is not gonna respond to any medication, and, you know, there's nothing really you can do. Except help them sleep, put them on benzos.
Do you see a lot of primary cares putting people on maintainer? Or, I mean, like, do you see that happening or?
Really? No, it's more like amateur psychopharmacology trying to do something that they don't know what they're doing.
Okay. I didn't know if like you
Primary
saw
care
that a
do
lot.
that. Most of the time they'll refer to me, or, you know, or they'll consult with me, yeah. So I do consultations too, so either they'll refer to me and I'll take over the patient, or the patient lives too far away from me and they want to see someone in person. And the primary care will consult with me and they'll document that we talked about it, and then I pretty much tell them what to do, right? So it's consultation. Obviously, they pay me for my services, but that's something you could do also. So technically, you're a specialist, right? So technically, as a psych NP, you're a specialist. So you'll have primary care doctors reaching out to you. Hey, I put this patient on different antidepressants. What do you recommend that, you know, I do next, right? You want to take this patient? You say, well, I have a full caseload. I can't take any more patients. Well, can I consult with you, right? We'll pay you consultation fee, whatever, and you tell me what to do next, right? And I'll try to manage it. If not, then of course they would have to go to another specialist.
What's your liability with that?
My
Is there
life-
any? Like if, I guess, because the actual provider is the one that's making the.
I don't think you're as liable because technically, you know, you're just consulting, right? I mean, they should have a general understanding too, that, you know, you're not directly treating the patient, yeah. Same way as if you have a collaborative physician, right? You do something wrong, they're collaborating with you, you're consulting with them. At the end of the day, it's your license that you still have to defend if anything goes wrong. Even though you consulted with you, they'll say, well, you have an education, you should have second checked that and said, well, that doesn't make sense, right? Why did that happen? So the liability is really mostly on the person doing it. Which is why a lot of, like, you know, physicians will charge collaboration fees, $500, $600 a month. I've heard about that for some NPs, just a private practice. Because technically you're paying me to consult with me, but it's zero liability to me, so why not? Right? That's a side hustle for a lot of my friends who are physicians. Right? Get a few NPs that are new graduates. I'll sign the collaborative agreement form. I consult with them. I charge them $500 a month until they reach their 100 hours. It's not a bad gig, but I mean, if they're actually helping you, but I know people that do it and don't even help the people that they're signing off on. But that's a different, it's another topic. Because technically, well, full practice autonomy, right? Once you get 3,600 hours, you're free to do what you want. That takes about 2 years, right? A full-time practice. Sorry, I'm gonna use the restroom. I'll be right back. You can think of questions. Well,
Is the exam gonna be open for 2 days again or just the 1 day?
You guys don't have a conflict, right? Not this time. Do you? Do you have a conflict with the other class? That was the only reason why they approved the 48 hours for the other test.
I haven't looked at, no, I don't think I do, but
Yeah,
don't know
think
what-
it's gonna be 24 hours because the only
Okay.
reason they approved it, yeah, it's just gonna be 24 hours this time.
okay. Thank you.
The best bet is take it in the morning when your cognition is best, right? Between 9 a.m. and 1 p.m. Don't take it at 6 p.m. or 7 p.m.
And so sorry, you kind of said this, but so there's no new material for the final. It'll just be,
Yeah, it's cumulative of everything we covered up to today.
Just going back, I think something it says with tolerance, is tolerance mostly that the receptors have, I'm sorry, my kitten's going crazy, have down regulated, and I know, yeah, because there's too much, so they down regulate to protect themselves, right? But I think, or could it be like up regulation?
Tolerance, give me so tolerance, say you're giving someone a benzodiazepine, right? You're
Mhm.
giving them, and that it's a PAM, positive allosteric modulator, right? After a while, the GABA is going to bind to the receptor. What's going to happen to that receptor with too much GABA? It's going to what?
Down regulate, right? Because it wants to protect
Down
itself.
regulate, exactly. Down regulate, right? So what's going to happen is they're going to be less sensitive, and there's going to be less of them. So what's going to happen? Your body's going to crave more. Believe it or not, you're going to have to go high.
Right, like the SSRIs. I know we learned in the beginning.
Yeah, similar to that. Yeah, that's why you need, But the funny thing about GABA though, with benzos, is that the euphoric effect is what downregulates, right? So patients say, hey, I need a higher dose of Klonopin, right? Or I'll just use Ativan or Xanax, right? What do you mean you need a higher dose? Well, is it because it's not feeling as euphoric it was before? Yes, right? Well, that's not what we're looking for. We're looking for the anti-anxiety properties. How is it with anxiety? It's okay, but I want to increase it because it was feeling good before, right? That's tolerance. Right? The euphoric effect, yes, your body develops tolerance, so you don't feel that same hit before. But technically, for an anti-anxiety aspect, you usually don't have to adjust it. So just be careful of that. Usually it doesn't, the anxiety doesn't adapt. You don't have to increase it due to anxiety. Sometimes you do, but usually not.
Right, thank you.
There's also links of GABA use with Alzheimer's. So we try to limit anticholinergics. That's the thing about psychiatry. A lot of our meds are anticholinergic. So we tend to give a lot of meds that are blocking acetylcholine. So blocking acetylcholine obviously is implicated in Alzheimer's, right? Because Alzheimer's is not enough acetylcholine. So why give them, especially if they're predisposed to it? And GABA at the same time is kind of like a blunt object, right? It's decreasing acetylcholine and everything else. So if you're giving someone GABA and a lot of acetylcholine, anticholinergics, you're messing with cognition. So
Would you have like a discussion in that class and like a big essay due like within that time period of the test? I don't know if they brought it, if you brought it up, if they would give us the the 48 hours for the test or not, like to taking the test.
you guys can ask me, and I can forward it to the dean and see if she says okay. Like I
Yeah,
said.
I'm just curious if they are, 'cause sometimes I know it can work better in schedules. I mean, I can make a schedule work no matter what, but sometimes having that flexibility goes a long way.
The thing is, historically in 517, 527, they've never done 48 hours before. So this is kind of like, I'm surprised they even did it.
Okay.
But I wouldn't push my luck. Because then 517, they're very strict. It's gonna be like only 1 day. So
Okay.
get used to it now.
All right.
And if there's a
Can you-
compelling reason for it, like last time when you guys had the same test for another class, but I don't know.
Can you explain the difference between dependence and addiction?
Uh, yes, I'm trying to think of one. I know they use interchangeably. I'm just trying to. I guess addiction is like when they're using something in socially, like say for instance, someone's using heroin while they're at work, right? They're using it in socially unacceptable places, and at that point, they're not even thinking about where they are anymore, right? Their life is their families is sacrificed, their job is sacrificed, and they're doing risky. That's more like addiction, right? Because they're not even thinking about it. It's part of the. Remember, it goes from the ventral to the dorsal striatum, right? Dorsal is when it's more automatic, right? They're using motor movements or just doing things, not even thinking about it anymore. So that's when it becomes addiction.
Okay.
Right. Dependence, it's kind of like, they stop using it and they start getting, I mean, usually one comes with the other, but sometimes not. Some people have dependence, but they're still not using it in socially unacceptable places, right? They use cocaine, but they know they're only using it on the weekends, right? They're not using it when they're at work. So there's still that. I guess you could argue that as people use it more, it becomes worse. Then once you get to the addiction part, it becomes even more dangerous. But no worry, I want to ask you the difference between that. I'm not worried about that. Ten minutes. Any other questions? Oh, by the way, when the course finishes and you want to keep watching my YouTube videos during the summer, I would appreciate it because it's getting my views up. I'm getting to a point where if I get 3,000 hour views, they might pay me like 10 cents. So YouTube. So if you guys can do that for me, it'd be great. I'm actually teaching for the summer too, by the way. Hopefully I don't see you guys, but there's gonna be a believe it or not, the same curriculum in 2 months for the summer for FNPs trying to get their Psych NP. So it's accelerated. Or if you guys don't pass this class, which I hope not, you guys can take it with me again in the summer, but it's gonna be less, much less time, more condensed. 8 weeks only. Actually, 6 weeks. I'm sorry, 6 weeks. 6 weeks only. Imagine learning all this in 6 weeks. And I lecture every week.
When would you start someone on methadone, or you really wouldn't unless they're coming in on methadone?
You have to be in a special clinic, like a special licensed clinic. So I've never started someone on methadone, so I can't tell you from experience. I've only usually done Suboxone. But I know historically, when people are started on methadone, they try to get them on a partial agonist, especially like Suboxone, because it's safer with naloxone there. And then they try to bridge them off if they can and just put them on an opioid antagonist like naltrexone. Yeah, that's usually the algorithm, right? Long-acting opioid, long half-life, start reducing it, putting them on an equivalent dose of a partial agonist like Suboxone with naloxone on it, get them to a good 12-step program. They have support groups, and then they do the opioid blockade, naltrexone. Hopefully stay sober. The problem is when people are used to a certain dose and they stop. That's the reason why I really think long-acting injectable is better. If someone's getting oral naltrexone, and then all of a sudden they forget to take naltrexone, and they use the same dose they were used to before, and their receptors are kind of downregulated already, they're gonna go right into respiratory depression, right? Because they're not used to that hit. Like fentanyl too, for people, like people are dying from fentanyl because it's like 100 times more potent than morphine, right? It has a long half-life. It's odorless, it's colorless. People add it to Xanax bars, they put it in everything. And when you give someone Narcan or naloxone, the half-life, like I said, of the fentanyl is longer, that people go right back to respiratory depression, right? That's the danger of it. And they even have like other synthetic forms of fentanyl, which are even it's called oxfentanyl, which is even stronger than that. That all you need is like a tiny little salt piece. It looks like a piece of salt, 3 pieces, and people get respiratory depression from that. It's crazy. Yeah, we didn't even talk about trank. right? But it's okay. That's another one. You guys know what Trank is, right? It's an alpha-2 antagonist. It's similar. It's related to clonidine and guanfacine, much stronger though. What happens? It cuts off the circulation to your peripheries, and people look like zombies. They have like really bad pressure ulcers, right? It's happening a lot in Philly. People are like having holes in their arms, and they're still injecting. It's crazy. People have to get amputated, their arms amputated. People die of infection, die of sepsis. So it's called Trank. It's an alpha-2 agonist, a very strong alpha-2 agonist.
They're injecting it.
They're injecting.
I just had a patient that came in with that, with
Trank.
the holes all over their arms. And like, I mean, it was the first time I had seen it. It wasn't my specific patient. It came into one of the hospitals that I work at, and it was like documented that way. And I didn't know what it was. So thank you for
Yeah, it's called
clarifying.
Trank. Yeah, it's called Trank.
And you're right about the fentanyl. I mean, we have just seen such an increase, and it's in everything. Like over the past week, I've probably called in like 3 or 4 live-on referrals for patients under the age of 40 that have just taken something and it was laced with fentanyl, and then they went into respiratory depression, cardiac arrest, and they're anoxic now. It's sad.
It's getting
It's
to a
really
point now. You just give everyone naltrexone, right?
Yeah, exactly.
As long as their liver holds up, right? Because that's very heavy on the liver. Yeah.
Hmm.
Methadone QTC interval. That's important to know too. So if someone's on high doses of methadone, make sure you do an EKG, right? QTC can be prolonged, right? And it causes an arrhythmia and they can die. So be careful.
Are they looking at like vaccines kind of for it, or like a prophylactic?
They
for-
are, but I don't know how far along that is. I've heard about it, but I don't know. It's not being offered, so I'm wondering if it failed trials or it's not safe. I don't know. They did have that at one point, like a vaccine idea, right? Where your body would recognize the molecule and destroy it, but I don't know why it never made it to market. I'm not sure. You should combine flumazenil with naltrexone, right? Flumazenil is the antidote for benzos, and that's my idea, by the way. If it comes out in the market, I'm gonna sue somebody.
Just get on the market before my kids are teenagers.
Yeah, it's scary. I know. Like naloxone's over the counter now. These people can buy it. I'm giving them out also. Yeah, I work predominantly child psych, so I see a lot of this. I probably work 60% right now, kids, 65% kids, and 35% adults. So it's everywhere. No one here want to work child psych or no? The need for it. There's a shortage of psychiatric providers. There's a 6-month waiting list for me right now at the clinic. Someone wants to see me specifically, not to brag, but you know, if people want to see me specifically, they have to wait 6 months. So they'll see a child psychiatrist before they see me.
Is there something you specialize specifically in with the children, or you just kind of take care of everything?
A jack of all trades.
Yeah.
I have to be. You know, I run the program of my organization, so I have to cover substance abuse, kids, adults.
Hmm.
So I have to be there. I do perinatal psychiatry too.
Is it like also like the neuros, like the psychiatry, like for like gifted testing, like all those like that stuff too, or just
What do you mean, like gifted?
other disorders?
Like autism, you mean?
Yeah, but like yeah, I guess like when they test kids for like ADHD, autism, but they also test them for like high IQ and giftedness as well. So they look for like different.
Yes. So even though I am a jack of all trades when it comes to mental health, I'm pretty confident in myself in treating a lot of stuff. There are certain aspects that I think kids should get specialized treatment for, like ADHD or high functioning. I usually refer them to like, and they get treated for that, but they also have like depression, right? So I treat depression, but they're going to another specialist. For instance, another kid who might have, you know, who's going to a specialist because they're, you know, they have gender dysphoria, right? They want to do the hormones. That's not my specialty, but I am treating depression, so they're going to go to the specialist there, get the hormones, and they still come to me for the psychiatric care. So I do a lot of collaboration, you know, or like kids who are overweight and they had, you know, they have to go to endocrinologist or cardiologist or whatever. So there's a lot of like, you know, special. It's very hard to, you know, especially with these meds, there's so many side effects that I hate to say this, but after like 5 or 6 years, they have to see a specialist for something else, whether it's endocrinology for weight gain, right? Or cardiology because they're having arrhythmias or other stuff. So that's a tough part about psych because it's really a multidisciplinary approach. This is the only way kids will get their best care. But you know what? The funny thing is kids will trust you more than their primary care. So I had a kid who trusted me more than endocrinologist, so I had to explain to them why they were on Synthroid, right? They didn't trust the endocrinologist. So I'm like, look, the endocrinologist prescribed this to you. This is what it's for. And I had to do the med teaching because they trust me because they've received me more frequently. So you have to be like the primary care and you're kind of like the gatekeeper to make sure that the patient is not being taken care, like advantage of, right? But some of these specialists will send them for like tests that aren't even needed. You know, it could be because, you know, their insurance is okay and they want to just do the full run up of tests, but it might not be for the patient's benefit. So you kind of have to like balance it out, you know, and advocate for them. And if you're not confident with your psychopharmacology skills, they'll walk all over you, right? You'll have meetings with like endocrinologists, nephrologists, and you're like, well, I'm the only NP here. Everyone else is a specialist, right? But you have to, you know, advocate for your patient. Look, I'm not stopping the lithium, right? This is the only med that's kept them from killing themselves. I don't like, okay, you're a nephrologist. Your job is to make sure the kidney's working, right? My job is to keep the patient alive. There's no substitute for it. What else are you gonna do? But they'll try to push you around and say, hey, you're an NP, you know, stop the medications, right? Or blame it on psych. It's a psych medication that's doing it. If you didn't know any better, you're like, okay, fine, I'll stop the meds. It probably is the psych meds. It might not be the psych meds. So that's why I'm trying to train you guys to really understand the mechanisms and know the in and outs of the meds because it'll really, you know, it'll save you a lot of time. I'll give you an example. Patient is on quetiapine. I'll go an extra 5 minutes because this is a good example of how pharmacokinetics can really mess you up, right? Patient is on, has bipolar depression. You guys know that quetiapine is one of the medications that we use, right? What happened was one of the neurologists put them on carbamazepine for, you know, pain or whatever. The carbamazepine is an inducer of 3A4, right? 3A4 converts quetiapine to norquetiapine, which is a potent norepinephrine reuptake inhibitor, right? If you guys don't know already, norepinephrine reuptake or serotonin reuptake can cause people who have bipolar depression to cycle. The patient became manic because the carbamazepine was added, right? Normally, you'll say, well, maybe I just have to raise the quetiapine. They raised the quetiapine. This is a true story, by the way. They raised the quetiapine, the patient became more manic. And no one knew that it was the carbamazepine inducing the quetiapine to an active metabolite that turns it to technically an antidepressant, which was worsening than the mania, right? Simple solution. Just stop the carbamazepine, give them something else, right? But if you didn't know that, you would keep increasing the quetiapine and you're giving them, it's like giving them Prozac, 100 milligrams for bipolar depression, right? You know that's not going to do anything. It'll make things worse. So that's why understanding pharmacokinetics can really save you a lot of time, all right? Plus, if a patient comes to you and they say, well, I'm taking these 2 medications, right? Someone comes to me and was on Prozac by the primary care doctor, saw a psychiatrist and they were put on Abilify. They started feeling anxiety. They didn't feel good. The psychiatrist was like, well, we'll increase your Abilify. Then they felt even worse that they fired the psychiatrist. Now they came to you, right? So what do? If you said, well, let me look it up. It seems like the fluoxetine, which is an inhibitor of 2D6-3A4, increased the Abilify. Therefore, that doctor maybe went too fast and you were having akathisia, right? Sure, that's fine. But what if the patient came to you and they explained that to you? You said, okay, easy. The reason why it's happening is because that medication was causing that, right? That connection from that patient, knowing that you knew that answer right away within 5 seconds, is very strong, right? That's a first impression. That patient is going to trust you now. You know, not saying that you shouldn't look stuff up, but like the more you have these aha moments where you can look things up in 5 seconds or not look things up but answer things like that, like a specialist should, patient will trust you, right? It'll go a long way for the patient connection. Yeah. Any other questions? Because my histamine receptors are starting to shut down already. All right. Thank you very much, everybody. All right. So the test is going to be on the same date. If you have any questions, just email me. All right. All right,
Thank you.
You're welcome. Bye.
Thank you.